All right. Hello, everybody. This is Maryanne Strobel. I'm the professional practice lead for Houston Methodist Willowbrook Hospital for diabetes. And it is my honor today to be able to present to you and give you a little bit more information and education on treating our pregnant patients who also have diabetes. So just to go over a little bit of the background to refresh everyone about pregnancy and diabetes. With pregnancy, women with normal glucose metabolism are often characterized by fasting levels of blood glucose that are lower than in the non-pregnant state. And this has to do with the mother being able to nourish the growing fetus, and the placenta plays a role in that as well. Mild postprandial or after eating blood sugars of being elevated and carbohydrate intolerance, again, can also be a result of these placental hormones. So there's two different types of diabetes that can occur with pregnancy. One of them develops during pregnancy. We call that gestational diabetes. And that develops during the pregnancy. It's not in existence prior to the woman getting pregnant. And some of the things that are normal is that glucose is going to be funneled from the mother to the baby. That is the normal way that the baby will be nourished. However, with gestational diabetes, this balance becomes imbalanced. And as a result, babies receive more glucose than they should. And as a result, can become large and can have problems with delivery. We do know that this propensity toward gestational diabetes is more common in some genetic lines, and that this unbalance can cause problems for both mother and baby. One of the first ways to try to control this imbalance, this gestational diabetes, is to be controlled with diet and exercise. And as the pregnancy progresses, as the placenta grows, it may become possible that the woman would require some insulin to manage the blood glucose levels. Gestational diabetes babies can be quite large and can even often weigh more than 9 pounds at birth. They may suffer birth trauma due to the large size, and as a result, they can have quickly changing blood glucose levels after delivery. Think about it. The baby is receiving a lot of sugar during the time it's growing, and when the baby is being delivered, the baby is going to lose that sugar supply when the umbilical cord is cut. As a result, the baby's own pancreas has been producing a lot of insulin to try to take in all the sugar it was receiving. And until that change after birth occurs and the baby's system stabilizes, they can actually have a low blood sugar after birth. Gestational diabetes born babies may also be more prone to developing obesity and or type 2 diabetes later in life. As a result of being very large, gestational diabetes babies or babies of mothers with gestational diabetes may require a C-section. Due to the combined stress of carrying the baby, women with gestational diabetes may even develop preeclampsia. And we have also found that women who experience gestational diabetes may go on to develop type 2 diabetes later in life. So this is just a little bit about the management of gestational diabetes. As I said earlier, one of the first things that will be tried will be lifestyle and behavior changes. So it's really important for women with gestational diabetes to be seen by a dietitian and learn about proper food choices. Now, women with gestational diabetes who are hospitalized, again, would also benefit from seeing a dietitian so that they can make some better choices from the diet they're offered here in the hospital when they're making their diet food choices. As the pregnancy continues, it may be necessary for women with gestational diabetes to also be treated with insulin. Sometimes they're also treated with some other oral agents, and the use of these oral agents is up to your individual physicians. I'm not going to speak on that. I will defer to your physicians. There's always some changes that are being pushed out through the professional organizations that your physicians subscribe to. And so what types of oral medications are currently being acceptable will be up to your individual physicians. Sometimes we'll see women with gestational diabetes who were previously using metformin for polycystic ovary syndrome, and they will sometimes continue with that medication. Again, I defer to your physicians about any oral agents. As far as continuing with gestational diabetes and looking at postpartum care, the insulin resistance decreases dramatically immediately postpartum, and insulin requirements need to be evaluated and adjusted as they are often roughly half the pregnancy requirements. So what I want to tell you is please watch your women who've had the use of insulin during gestational diabetes. Please watch them carefully after delivery for any potential hypoglycemia. So again, work with your physicians. And then as far as education that you can provide to these women, they may be asking you about going forward, about, contraceptive plans and or thinking about having babies in the future and how to keep their cells healthy and keep their blood sugars under good control prior to conceiving the next time. And we always tell women who've had a history of gestational diabetes that they should be going to get an oral glucose tolerance test after they give birth. So they'll be following up with their physicians after the birth, and then they'll work with their outpatient physicians about following up to see if their gestational diabetes has been fully resolved. We do know, however, that women with a history of gestational diabetes do have a propensity toward having type 2 diabetes later in life. And so it does become very important for these women to continue to choose healthy foods and to continue with a healthy lifestyle. So because the number of pregnant women with undiagnosed type 2 diabetes, it's reasonable to test women with risk factors. So these will be women that will be getting tested before they would come into the hospital and have some of these risk factors, such as being overweight, having relatives, first-degree relatives with diabetes. We know that it's more prevalent in certain ethnicities, women who have prediabetes, and as I said, polycystic ovary, and have had prior gestational diabetes. So this is just telling us a little bit more about the recommendations. Some of these recommendations come out of the American Diabetes Association. Every year they publish the standards of care, and that's where I've gotten this slide from. And these are just some of the recommendations talking about the oral glucose tolerance test. So now let's talk a little bit about patients with pre-existing diabetes and then they get pregnant. In patients with pre-existing diabetes, glycemic targets are usually achieved through a combination of both insulin and medical nutrition therapy. So what that means is they'll probably be starting on insulin, earlier during the pregnancy. And as I said earlier when we first started this slide deck, glycemic targets in pregnancy are stricter than in non-pregnant individuals. And again, that's because we want to make sure the baby gets the right amount of sugar and not getting more sugar than they really need to have. And so it's important that women with diabetes, whether it's gestational or pre-existing diabetes, Eat consistent amount of carbohydrates to match with either the insulin dosage and to avoid hyper or hypoglycemia. Again, dietitians' referrals are very, very important. And just to clarify, I am not a dietitian. I am a certified diabetes care and education specialist, but my primary discipline is nursing. And so when I come to teach your patients, my focus is going to be upon teaching insulin, talking about the risks and benefits of good control during pregnancy for the diabetes. But as far as teaching the food, the diet, or anything in regards to nutritional management, please contact the dietitians. So early pregnancy is a time of enhanced insulin sensitivity and lower glucose levels. Many women, even with type 1 diabetes, and as you know, there is a difference between type 1 and type 2 diabetes. Type 1 diabetes is actually an autoimmune disease, normally will surface, and women will be diagnosed with type 1 diabetes prior to the age of 30. Often they will even be diagnosed as children. They will have lower insulin requirements and an increased risk for hypoglycemia, and I can't emphasize that enough. They will have a higher risk for hypoglycemia. As far as your hypoglycemia parameters, I'm going to defer to your individual physicians at this point. What I do have knowledge of for our hospital system is that we do treat anything less than 70. 70 is in our adult hypoglycemia policy, which is PCPS 142. I do know that currently there is some conversation going on between our lead endocrinologist for the Houston Methodist System, Dr. Sadhu. She is talking with your OB council about these parameters. I don't have any more information for you on any changes in that regard. I will defer to your individual physicians. And I will also just like to tell you that we do have Dr. Karimi. He is currently our inpatient consultant, endocrinologist, and I would highly always recommend that if there is concern, that your physicians can reach out to Dr. Karimi for a consult. So this is what I pulled from our order set. These order sets are systematized throughout the Houston Methodist System. And this is what I found in the peripartum diabetes management for oral agents and subcutaneous insulin. And these were the parameters for the target blood glucose levels that I found. Again, I will defer to your physicians who may want to individualize some treatment goals for each patient. But this is what I did find in our system order set. So I'll read those to you in case you're just listening in by phone. But fasting is less than 95, pre-meal is less than 95, 1 hour postprandial after eating is less than 140, and 2 hours postprandial after eating is less than 120. Again, talk with your individual physicians in case they are individualizing. So let's talk a little bit about best practices that have just recently come out through the system. And this is really important. You might have already seen this happening in the MAR. And right now in the MAR, we are getting best practice alerts, or BPAs, if our time between point of care finger stick and insulin dose is off of the timeline. Right now, our orders state that for short and intermediate acting insulins, your blood sugar finger stick should be within the last 30 minutes. So if you're going to give insulin, short acting insulin, which is regular, or a rapid acting insulin, which is Lispro, or an intermediate acting insulin, which is NPH, your point of care finger stick should be within the last 30 minutes. So if you're giving it at 8 o'clock, that blood sugar should be no older than 730. So if it is greater than a half hour, greater than 30 minutes, you're going to see a best practice alert pop up in the MAR. It's going to direct you to get a more current blood sugar. Long-acting insulins and oral anti-diabetic agents, if you're using any, they do give you up to 60 minutes. So if you're giving this long-acting glargine, for example, insulin, or an oral agent at 8 o'clock, then it can be as far back as 7 o'clock that that blood sugar was taken. However, if it is older than that 60 minutes, it will prompt you in the BPA to get a more current blood sugar. And again, the hypoglycemia standing orders that we have for the whole house is less than 70. And again, I don't have any more current information for you on that, but I always defer to your physicians. I just wanted to show you a little bit about what this BPA is going to look like in the MAR. Like I said, you might have already seen this pop up. And if it is outside of any of the windows of the insulin that you're going to be given, it is going to pop up and remind you that you should acknowledge that you will get a more current blood glucose value. If you have patients refusing to be giving their finger sticks again, then all I can tell you to do at this point is to escalate to your charge nurse and or to your manager. We certainly can't force people to work with us, but please try to help your patients to understand that this is for their safety. And this was a decision that was made, system-wide in order to ensure patient safety. If you have any more questions on that, you can reach out to me. And of course, then we would reach out to the System Diabetes Action Council. This is just a little chart here that's showing you the onset, peak, and duration of our different insulins that we use. I think you'll find this chart very, very helpful. So I hope that you will look over it. It does talk about our rapid-acting insulins. Currently, that is Admelog, insulin Lispro. That starts to work in about 15 minutes, 10 to 15 minutes. It's going to peak in about an hour to an hour and a half, and we usually say it lasts in the system about 4 hours. Short-acting insulin is regular insulin. You can read that for yourself. That has a little bit more elongated onset, peak, duration timeline. And then intermediate action is NPH or NPH 70/30, which is an insulin mix of regular and NPH insulin. All of those that I've mentioned have to be within 30 minutes or less prior to insulin administration, your finger sticks. Your finger sticks have to be within 30 minutes or less prior to insulin administration. Our long-acting insulin that we use here is insulin glargine, and that you are allowed to have 60 minutes or less prior to insulin administration with your finger stick. This is just a slide showing glycemic management and newborns. I believe that I either got this directly from your nursery or I got it off of one of our order sets. Again, I usually do not go into the nursery or the NICU. Your neonatologists are very good experts, and so I would always defer to them. But if we have some of our new policies and or order sets, then taking this information from. This next slide here shows the adult hypoglycemia algorithm. Again, that's in our policy PCPS 142, which is the adult hypoglycemia policy. This is how to look at your patient's blood sugars if they're less than 70, what to do with the initial blood sugar that's less than 70. This is nurse initiated. Nurses can respond and are expected to respond immediately when they find blood sugar less than 70. Again, I know there's discussion in the women's services area across the system, so I don't have more information on any changes. This is what I will adhere to until I hear anything else. There is also information on this algorithm about the recheck. So if your patient does have a low blood sugar that you're treating, whatever the number that is, you are expected to go back and recheck that blood sugar within 20 minutes to see if that hypoglycemia is resolving. If that second blood sugar is still less than 70, it gives you directions on other things to do. And then when you go to recheck after the second to the third time, if that third bedside blood glucose is still less than 70, there are further orders in there. I know that in women's services, you would probably be well into having conversation with your physicians prior to getting into that point. The next thing I just want to talk about really quickly is diabetes and insulin pumps. Sometimes we do get pregnant women in who are also using an insulin pump. They have usually pre-existing diabetes with pregnancy. I do want to remind you that we do have a system policy. It's PCPS 154, and that there is an agreement form that the patient would have to sign, mostly stating that they're going to allow us to do finger sticks, even if they are wearing a secondary sensor. We still will do finger sticks on our patients. And the patient then assigns that agreement, also signs that they are going to provide their own insulin pump supplies. I do not have insulin pump supplies here. Patients must bring those in with them in order to continue using an insulin pump. I will also like to mention that if your patient is pregnant and using an insulin pump, again, that would be a really good recommendation time for Dr. Carini, our inpatient endocrinologist consultant, to be put on the case. And again, that order would come from your physicians. And we also ask, part of our PCPS 154 policy is for the patient who's wearing an insulin pump to daily fill out the bedside glucose and insulin log. And that's so that any changes to their glycemic control can be determined by the physician, who would then know how much insulin the patient was taking. I do also want to enlist your help in teaching our patients who are pregnant and have diabetes. You know, we do have a team effort here at Houston Methodist Willowbrook. I am the only inpatient diabetes care and education specialist, so I'm a scarce resource, so we work together. And if you're not refreshed on diabetes and pregnancy, we do have booklets that are available on our intranet page. And I'm going to show you that in the next few slides on how to access them. You can print those out for your patients until I come to see them. I encourage you to look at these booklets and read over them for a refreshment of information and education for yourselves. Remember, there's other members of the team here at Houston Methodist Willowbrook that can also help your patients who have diabetes and pregnancy. We've talked about the dietitians. I'd also like to tell you we have the clinical pharmacist. They're very good at teaching insulin, so they are available. We have our diabetes resource clinicians. I'm always happy to bring women's services nurses and also PCAs if they're interested. If the managers would like to send me some of those representatives, we do meet once a month. It is a 1-hour class, and I'll be happy to have them join our team. We have our social workers who can help with any resource needs, as well as case management. For behavioral health issues, we have our DISRIP behavioral social workers. We have our transition of care case management nurse, of course, your physician, and then you can advocate with your physician for your patient to be placed with outpatient diabetes education if needed. Sometimes I know they come in, they're not ready to deliver. They'll be here for a short amount of time, but then be transitioning back home until delivery. And if that is happening, I would really strongly encourage that they are linked with an outpatient diabetes care and education specialist until they're ready for delivery. The next slide here is just showing you how to access our intranet diabetes education page. Here at Houston Methodist Willowbrook, from our home screen, our intranet page, you would go to nursing, click on nursing, and the next slide you would see here is going to be with Nicole's picture in the middle of that page. And on the bottom right, you'll see it says HM Diabetes Education. You would click on that, and then you would see there was something called patient care. You would click on that, and there's where all of your patient care resources will reside. In there, there will be your diabetes and pregnancy booklet. And like I said, you can even print one of those out for yourself and refresh your own knowledge. There's also one, it says, thinking of having a baby. That's nice if after delivery, a woman would like to take a copy of that home, which tells her how to prepare to keep her blood sugars under control if she's choosing to have another pregnancy. So prior to conception, it would be very important to have good glycemic control. Our insulin pump policy and the handouts that I talked about as far as the bedside glucose log and the agreement are also available there. And there's also a link to our hypoglycemia PCPS 142. So that's what I have for you today. If you have any other questions, since this is recorded, please email me. My email is mstrobel@Houston Methodist, and I'll be happy to answer questions. You can also reach out to, Kristen Lynch, and she can always get a hold of me. Thank you so much for your time. I really appreciate it. Bye-bye.